Hello, everybody. My name is Dr. B. Ravi Kumar. I'm an endocrinologist practicing at Madhava Hospital in Nizamabad in Telangana. It gives me a great pleasure to share with my colleagues across India about a case I would like to discuss. It's a new patient who's been diagnosed with type 2 diabetes but has got a high HbA1c. So we all have a clinical dilemma as to say is that what should we do to these patients? So to go through the process, let's discuss the case. I'm going to talk to you about a case of 45-year-old gentleman who's been diagnosed with type 2 diabetes 6 months back. He's got multiple risk factors like obesity, hypertension, and dyslipidemia. He was seen in the clinic and rightly started on metformin and has been advised for lifestyle intervention with diet modification. He visited back again to the clinic as a routine checkup. But when the blood test was done to assess his diabetic condition, in the laboratory test, his HbA1c has come back as 8.5. His eGFR is 80 mils per minute. LDL was 80 milligrams per deciliter. HDL was 38 milligrams per deciliter with triglycerides 200 milligrams per deciliter. Looking through his medications, he's on metformin, 1000 milligrams BD, lisinopril, 40 milligrams, metoprolol, 100 milligrams, atorvastatin, 40 milligrams OD, aspirin, 75 milligrams OD. On examination, he's been obese with a BMI of 31 kilograms per meter square. His blood pressure is about 120/70 with a resting heart rate about 80 beats per minute. Now, if you look at his condition, he has been studied on metformin rightly, but his glycemic control is not what we want to achieve. We always know from the UKPDS data, if you want to prevent or delay the microvascular and macrovascular complications, we need to intensify the therapy. The UKPDS has clearly shown that patients who were on intensive therapy had lesser cardiovascular events compared to who had a normal therapy. So early intensive therapy is always beneficial because it has clearly shown that the legacy effect is not there when you try and control the sugars very early. If you look at conventional therapy with intensive therapy, though the HbA1c has not been different at the end of the therapy, what mattered was the aggressive initial treatment to prevent the complications. So the point of what we are trying to make is when you've got a patient whose sugars are not well controlled on just oral therapy, which is metformin, then you've got to think of dual therapy. And the reason is this patient is at high risk of cardiovascular disease. So we would want to use something which can cause weight loss and can prevent cardiovascular disease. So we've got two such agents that's available for us, which has already been acknowledged by the American Diabetes Association and the European Association, that you can use a combination therapy like SGLT2, like empagliflozin or DPP4, because SGLT2s can cause weight loss and has got cardiovascular protection. And your DPP4, like linagliptin or any other DPP4, which could be a combination therapy that could be considered in this patient, because we want to achieve a good target quickly when they've got such high HbA. So for such clinical reasons, starting them on combination therapy always works. There has been a proven data from the meta-analysis that suggests that using a combination therapy significantly increases the likelihood of achieving your HbA1c of less than 7 compared to the monotherapy. As for the current generation of treatment for diabetes, we are no longer relying on one drug therapy. We are wanting something more, because what we are trying to do is we are going from glucocentric to multi-organ protections like your cardio-renal. So we want to try and get the metabolic factors rightly corrected at the beginning, not at the end when they've already developed the complications. So if you've got patients who've got HbA1c of more than 1.5 above the goal at diagnosis, ADA and ESD guidelines correctly recommend that you need to start them on dual therapy, and you can choose the drug of your choice as per the patient's requirement. And if the patient has got a high risk of cardiovascular disease, heart failure, or CKD, then you would think adding on an SGLT2 or GLP-1 would be a good combination. The whole point here is SGLT2 and DPP4 they complement their mechanism of action for the benefit of patients. And nowadays we are more interested in these drugs because of its pleiotropic action across all these high-risk patients with cardiovascular disease. And it also shown that it's very beneficial in patients with renal problems. So if you've got patients who are not achieving the HbA1c, You got to use the right drug of choice based on the profile of your patient. And these drugs have clearly demonstrated when you use an SGLT2 with a DPP4 in patients who are obese with cardiovascular risk, there's a significant reduction of your HbA1c, about 1.81% at 24 weeks compared to the metformin treated groups. So the combination therapy works. It's a suitable strategy for your patients. The mechanism of action is slightly different because it's not beta cell dependent for the SGLT2. So you're trying to keep the beta cells for longer for these patients. And again, when you're using an SGLT2 with DPP4, the additional benefit is there is a reduction of the genital infection, which is associated with SGLT2, which is an added benefit when we start to use these drugs earlier in the course of the treatment than later. And because of this combination of therapy using dual or triple agents, you're able to control the metabolic factors, can do a weight reduction, get the glycemic parameters corrected, and you could reduce or delay the microvascular and macrovascular complications. So what really I wanted to get my point across is, we have to start using a dual agent early in the course of disease when they do not have a good glycemic control. We've got a lot of evidence-based medicines, and we are using a lot of SGLT2 and DPP4 for its good reason in terms of cardiovascular renal protection, because we want more of a pleiotropic agents that we need. And we've shown that by using these combination therapy, you can get a HbA1c reduction 2 to 4 times higher odds of patient reaching a good HbA1c with low glycemic risk is what is required. So in short, my dear colleagues, try and be a bit more aggressive in trying to treat your patients, look at your profile, use the drugs wisely, and prevent the cardiovascular and renal complications for the benefit. Thank you very much. Namaste, Jai Hind.